All right. Well, welcome and thank you all for joining us tonight. We'll be continuing our Association of Program Directors for Colon and Rectal Surgery Robotic Surgery series with Dr. Amanda McClure. But first, I have a few announcements. Applications for next year's leadership team will only be open for the next 11 days. You can use the QR code on the screen to link to more information about the two positions and the applications. There's also a link at the top of our Twitter profile, and we will include the information in our weekly email this next week. As a reminder, trainees who will be a colorectal fellow starting this August can apply to be on our leadership team. In this role, you will plan and implement lectures for the next year and work with our partners behind the knife and Surgeon to continue to grow and improve our content. Trainees who will still be in residency for the next academic year can apply for our surgical education fellowship. This part-time fellowship is brand new and is being created to offer the opportunity for general surgery residents to gain experience in the evolving world of digital surgical education. In this role, you will support the leadership team and gain valuable mentorship from colorectal surgery fellows and faculty with a passion for surgical education. In addition, you will have sponsored registration to virtually attend the annual Digital Education Conference hosted by Harvard. If you know of any trainees who may be interested in either position, please let us know. In addition, we're always looking for recommendations for speakers and topics for our lecture series. If you have anyone you would like to see give a talk, please send us a message. Now on to the topic of the evening. This is the second year that the Colorectal Surgery Virtual Education series has partnered with the APD CRS Robotic Surgery Curriculum to live stream and record the lectures. We have a great lineup of speakers who will touch on many aspects in troubleshooting and robotic surgery. As a capstone to this lecture series, fellows will have the opportunity to travel to Atlanta for a hands-on course with Drs. Bastaros, Cleary, and Solomon. I have the great pleasure of introducing Dr. Amanda McClure, who will be teaching us about mastering the robotic TME dissection tonight. I've been lucky enough to be her fellow for the last 8 months. Working with Dr. McClure in the OR is the best. She has so much energy, which she translates into incredible efficiency with the operative team. I've learned so much from her this year, and I can't wait for you all to do the same tonight. Dr. McClure is a board-certified general and colorectal surgeon. She specializes in robotic and laparoscopic surgery, as well as minimally invasive transanal procedures. She has clinical interests in the prevention, diagnosis, and treatment of colorectal cancer, in addition to diverticulitis, IBD, anorectal, and pelvic floor disorders. Take it away, Dr. McClure.
Awesome. Well, thank you guys so much for having me tonight. First of all, I just wanted to say congratulations to y'all. I mean, you have got 8 months of fellowship under your belt. And so that's super exciting. You know, you're 2/3 of the way through. And so we get to spend some time tonight talking about TMEs, which is, one of the most challenging things that we do as colorectal surgeons, but also one of the most rewarding. And so want to just say congrats to you. And also, I tried to make sure that tonight and again, ask questions as we go along. Please make this as interactive as you want. I really tried to include the tips and tricks that I wish someone would have told me when I was starting out, things that I figured out along the way, and I tried to include them for everything as we went along. So hopefully you'll find some of this useful, and we'll get started from here. So a little bit about our program. I have done almost 500 robotic procedures. About 1/4 of my volume is rectal, and about the 3/4 is abdominal. I trained in 2014 under Dr. Mark Solomon, who, if you can believe it or not, at that point was just starting robotics. So I was really great at bedside, but I obviously loved the robot. I saw the value in it, and then came out of the program and really took advantage of the intuitive opportunities and trained myself, started adding cases. And, my very first robotic surgery that I did was an APR. I wouldn't recommend starting that way. But sometimes, you end up in a practice where you just kind of have to get started. So, uh, you know, better anyway than never. We made it to where we are, and that's what matters at the end of the day. And now I'm an all-in robotic surgeon. I do everything robotically. The nice part about our program is that we have 4 robotic surgeons, and I'm lucky enough to partner with Dr. Robert Cleary, Dr. Melissa Chang, and Dr. Beth Ann Shanker. And so we have a robust robotics program. We are on, I think, 475 cases this year is where we're on target to make it. And we're also incorporating ACS, our acute care surgery robotics program, with 24/7 access lines, and we have access to 24/7 urgent lines for robotic surgery as well. So we're extremely lucky. We built this practice, and We also train fellows and residents, which we love doing. Matt says that he's lucky to spend time in the OR with me. Sometimes I wonder, I'll have to ask him. Some days I'm sure it's a little bit challenging, as it always is, but we're so lucky to have him. We had Sarah Diaz last year. We just appreciate training fellows, and it's really important. So I'm going to spend some time talking about treatment of rectal cancer. We're gonna kind of jump in and go from there. Obviously, there's always the discussion about why the TME and why is the plane important. As we all know, surgery is the mainstay of treatment as far as making sure that you do a great surgery. So you have to do an excellent surgery. As you know, I think the quoted data is there used to be like a 30%, 30 to 39% rate of recurrence with surgery when you weren't doing a total mesorectal excision, and that significantly changed to a rate of recurrence about less than 10%. So significantly improved. And then even with, we learn more all the time. And so as we're looking at incorporating rectal preservation, I think like with the Oprah trial that's come out, now we're looking at doing total neoadjuvant chemotherapy and following that with surgery for those who aren't an option for watch and wait. So for those people who do have total neoadjuvant chemotherapy, most of the time we do consolidation at first, which means that they get radiation and chemotherapy up front, followed by chemotherapy, followed by restaging. And at our institution, we have a complete clinical response rate of about 50.7%, which is on par with Memorial Sloan Kettering. So again, for those patients that do significant, that do have the complete clinical response and can go onto the watch and wait program, that I'm not going to cover tonight, but for the ones that do need to go to surgery, that has significantly decreased our overall volumes. And I think that's something that, we struggle with now. We're seeing the patients that are a lot harder or that are more involved. And so I think it's going to change our rectal cancer treatment, surgical treatment landscape as we move forward, because we're going to be doing these, it's not going to be the easy pelvises. It's going to be difficult pelvises with invasion into other organs. There's some reason they're not responding to chemo and radiation. And a lot of it has to do with the biology of the tumor. So jumping into the surgical management, why total mesorectal excision? Because we have the ability to positively affect our patients by curing them of their cancer and decreasing their local recurrence rate. So we really want to make sure that we're offering great surgery. And again, I choose to do a TME robotically. I think there's different ways, there's open, there's laparoscopic, whatever way you do it, you just need to do it excellently. And so robotic, I'm going to talk about robotic tonight, but that doesn't change the fact that you need to offer excellent surgery and follow the surgical principles. So I'm just going to throw that out there. When we talk about quality in rectal cancer surgery, how is it measured? It's measured by surgical grading. So the pathologist will give you a grade as far as whether the TME is complete, almost complete, or incomplete. And that makes a difference as far as the survival of the patient. And so that, is important because as surgeons, that's how we get graded, and it makes sure that we're offering excellent surgery to our patients. The other part of this is the quality of life. So we have to watch, we have to make sure that we're also talking about the sexual and urinary dysfunction that patients will get. And also, as we all know, pelvic floor dysfunction, especially with patients who have had low anterior resections, pelvic floor, oftentimes we'll have to have pelvic floor physical therapy, things like that. I think that kind of segues into the importance of informed consent when you are talking to your patients up front. So it's important to know that nothing that we do to anyone is without side effects potentially. And so really making sure that you spend the time to figure out what is their continence before surgery? What can I possibly do to them that can make them worse or better? What are they willing to tolerate? And also, things that are important to them as far as urinary and sexual function makes a difference as well. And really making sure you can adequately counsel them preoperatively so that postoperatively, if they do have sexual urinary dysfunction, you've talked about that and covered that, and it's not a surprise to them. We could not talk about surgery at all without anatomy. So, the picture on the left here shows what we would love for everything to look like. Everything is held up, nothing's falling down, and there's a nice space between this uterus, rectum, and everything's straight. What mostly looks like is that the bladder, the vagina, and the rectum are here, but a lot of times in female pelvises, you have to be careful of rectoceles, cystoceles, and overall prolapse. So just some things to look out for as your preoperative planning. And in the male, a lot of times most of the issues are that it's extremely low pelvis, small spaces, and a lot of times just keeping out of the prostate and figuring your way around the rectum is really important. So that's some of the anatomy. Um, we'll talk about the autonomic nerve preservation because that's really important. I think that's one of the side effects out of all the things that patients care the most about. And they want to know that they're going to be whole after the surgery as much as we can make them. And that makes a difference in how we operate, but also how we counsel them. So just reviewing the nerves, because I know this is always a hot spot on boards. The sympathetic nerves are at the root of the dissection and IMA, and that is where you can have stress urinary incontinence for urinary dysfunction, and then also retrograde ejaculation. Those are sympathetic. So if you remember the point and shoot from med school that we all learned, they're the shoot section of life that we don't want to bother. The hypogastric nerves are oftentimes injured in the posterior dissection. So those are the ones that you can see most likely they start medially and come around laterally. And so we want to make sure we stay out of those because that as being part of the parasympathetic. I'm sorry, they have mixed. So they have parasympathetic and sympathetic. They can alter both parts of everything. So we really want to make sure that we don't get those if we can help it. The nice part about robotics and is you can see everything, all the planes. So hopefully you can avoid them if possible. Sometimes we can't because they're going into the tumor and we have to take them. So again, the preoperative planning is really important, reviewing the MRI, knowing what potential side effects or complications that patient's going to have downstream is really important. The splanchnic nerves, also called the nervi arrogentes, can usually are harmed during your anterior dissection, your posterior dissection, but when you're pulling up off the rectum. So those are more parasympathetic, so they're the point section. If you have IHP, the lateral dissection, so that makes a difference, and it makes a difference if you're having one-sided or both. So hopefully, you hope if you get one at all, you get one, but the goal is really to get none. That neurovascular bundle, which is in the anterior dissection and then right between the prostate. So those are the 5 different places that you can have nerve injuries. And so we just really want to make sure that we avoid it during those times. Again, this is another picture just showing the same thing, that we really want to make sure that we're staying in the correct plane. And I'll point that out when we're operating. It's very, very easy to get too deep, and these planes should be bloodless. And I say bloodless, but we all know, we've all been there. So the patients most of the time have gotten chemoradiation. And so when I say bloodless, they're always a little bit juicy, edematous, sometimes difficult to tell, but you really want to make sure you're dropping down on the retroperitoneal attachments and not pulling these nerve bundles up if you can help it, identifying those hypogastrics as they come around so that we're not getting them inadvertently. So again, I kind of think of rectal cancer like preparing for battle. You never know what you're going to find. You do your best for preoperative planning. They go through multidisciplinary tumor board. They're discussed. We look at their MRIs. We look at their surrounding structures. We look at their preoperative states, how they're doing, if they're a good operative candidate. But you kind of have to know your opponent. So always evaluate your preoperatively. So your GI colleagues will evaluate. We all have been there where, they say it's a rectal, but it's actually a sigmoid or things like that. Just look yourself. Please, please, please look yourself. Know what you're walking into, know how far you are, feel if it's fixed, does it correlate with your MRI, know that walking in before you go into the operating room. And then also make sure that some of the times that when they have had operative surgery previously, or they are obese, or you're going to have a really big specimen, where are you going to take it out of? How can you set yourself up for a successful surgery? That's what matters. Intraoperatively, just get the suction ready. You're going to need it. Be nimble, be flexible. If you can't, work till you can in one place, and if you can't, switch to another place. I call it rocking the colon, because you literally have to go in from every colon or rectum, I should say, but you have to go from every angle and just really make sure you keep moving forward. And sometimes the progression is really slow and it can take a long time. It's never going to be easier open. You're not going to be able to see better open. And so I always remind myself that, because usually a few hours into the dissection, I pull my head out of the console and take some deep breaths, or, Bobo can tell you that there might be some expletives. So either way, get your head in the game. Know it's going to be a difficult dissection. Sometimes they're really easy. Huge female pelvises, that are 5-car garages are totally great. But when you are in a small male pelvis trying to dig a cone out of a cone, it's going to be, a kind of a difficult and long process. So just go into that knowing that. And I would say, just when you get out, planning wise. So when you're planning your surgery schedule, if you know you're going to have a big rectal cancer, don't put another big rectal cancer behind it. Especially take care of yourself, take care of your teams, make sure you're planning so that you're not forging ahead and burning yourself out early. So how do I set up for a robotic left sigmoid LA or APR port placement? So bed positioning is in 25 degrees Ted Ellenberg, 10 degrees left side up. Make sure your patient's strapped to the bed well. My arms are set up. So I used to set up, some people do still set up across like this. I prefer to set up more at a steeper angle because I don't, I sometimes couldn't get to the flexure easily, especially for very high flexure. So I started backing my ports up on a steeper angle, and I've been really happy with this port placement. For rectal cancer dissections, I always give 2 ports. I always give 2 hands for my assistant. We are lucky enough to have PAs at the bedside. And they're very well-trained PAs. So I always have extra hands in case I need it, especially in those obese male pelvises where you're pulling, but you're almost getting no movement because the tissue is so fatty. I will extract either at arm 4, so down here via the right lower quadrant incision, a fan and steel incision, or sometimes transrectal or transvaginal extractions, depending on the anatomy of the patient. For rectal cancers, I'm not doing a nose extraction, but that's an option for benign disease. And then if you need to, if there's a planned ostomy, you can oftentimes extract at arm 3 because you're already making that, that's large enough that you can bring your specimen out as well. A lot depends on what the specimen looks like, what the patient looks like, and what you think is going to work for you. The other thing I would say is when I'm putting the ports in, I really want to make sure that I'm imagining that pelvis. So you don't want to put your port too lateral so that you hit the port the whole time and you're trying to get to the pelvis and you can't get there. So that's always one of the things that you just have to make sure you go a little bit more medial. Imagine where your pelvic bones are and stay a little bit more medial. But if you run into problems, you can actually put your stapler in arm 3, move your camera over, and then come in that way too, which actually works really well for an anterior posterior dissection. Or a stapler line, I mean. For me, lefts get 2 lefts, and then I always remember that lefts get 2 lefts. So I always put 2 left hands, the camera, and then the right side, and rights get 2 rights. And then again, 2 assists for a TME.
Dr. McClure, can you check and see if you're in presenter mode?
Presenter mode. Do you
Try
mean
clicking play up in the top?
Oh no, I did it on purpose. I'm sorry. I know.
That's okay.
I didn't do presenter mode because I really want to talk about my videos later. So I'm sorry. I didn't do it on purpose because I can't stop my videos. So surgical steps of the TME. When you restore your normal, first thing you want to do is restore normal anatomy. And I like to open my peritoneum laterally first. So I know it's very difficult when people are doing the medial to lateral dissection. It is difficult to find that perfect plane between your ureter and the tissue above it. And so I really like to open my lateral peritoneum all the way down. And then I make sure that I open it medial to the ureter itself so that way I can find the ureter. And then after I pop into that plane, once I find the ureter, I've already dissected through and it's very easy to get behind there and get through the IMA. That's one of the things that's helped me. And I'll, show you some examples. Hopefully it'll help you too. And I always do splenic flexure mobilization. I am an always splenic flexure mobilizer. I know some people are sometimes, and that's fine too. But I always do the splenic flexure mobilization first because if I had to convert, I have already done the splenic flexure mobilization, and then I am able to do the rest of my dissection through a fan and steel incision should I need to. So again, splenic flexure first, and then I go to the pelvis. And then at the end of the day, when you're done with the entire surgery, you've already done the flexure, you've done the pelvis, you're ready for your anastomosis, and you're ready to be done with the surgery. So for me, it works better that way. Then I do medial to lateral dissection, then TME, and then again, intracorporeal anastomosis is how I do it, but everyone does it a little bit different. Whether I'm doing an APR, at that point, I would then do the APR dissection. I currently do it in lithotomy position, but some people like prone. The nice part about the robot is you're able to go down all the way to the pelvic floor. You can almost do, I'll show you in a little bit, but I actually open up the posterior levators and I kind of make a U. And so when I go down below, I'm basically going all the way down to skin robotically almost. And then I just pop in posteriorly and can open up the levators. And then all I have left is the anterior dissection. So it makes that dissection really, really easy. And then plus or minus diverting loop ileostomy. I use ICG all the time for all my pelvic cases. If you don't or you haven't, I would highly recommend using it or checking into it. We are credentialed to do our own cystos, which has made a significant difference. And so we always are able do our own cystos, put ICG in, put a stent in, and keep our ureters out of trouble. We inject with a 5 French stent, and then I inject both ureters with 3 cc's and then pull everything out. The ICG lasts the entire case, and it really does help when you're finding the ureter. So definitely something that I lean on to stay out of trouble. I'm going to talk a little bit about splenic flexure mobilization. And so when I mobilize flexure, I will usually do lateral to medial first, but I've started doing medial to lateral. Mike McGee at U of M is doing it, and I heard that he was doing the best splenic flexure mobilization ever. And so I said, well, how's he doing it? And of course, you know, he's doing medial to lateral. And so I started doing that, and it has been a game changer. So I'll share that with y'all as well. Sometimes I think with the flexors, you really need to be able to move around and know how you're gonna. If you can't tackle it lateral to medial, then you need to go medial to lateral, and you need to be able to have different things in your armamentarium to be able to work through that. So with the flexure that we just showed you, I'm using my third arm to pull. Usually I'll use it to pull down, actually. And if you pull it down for the appendix, you have no problems with collisions, and you're able to work around your with the other 2 hands. The other, you can sometimes bring that omental collar ligament up and out, but it just makes it a lot easier when you can bring that arm 1 down for the pelvis, and it really just keeps you out of trouble from collisions. I mobilize all the way, the kidney comes all the way off of that medial colon right here. And so you really want to make sure that when you follow it up from ureter down here, you follow that all the way up your medially, and you'll have enough length. And that's why some people don't mobilize flexure, they have enough, but for an LAR or something like that, you're probably going to need to do it. And also you want to do a high ligation of the IMV to make sure you have enough length. So again, you really want to get underneath the colon. My fellows, I'm sure, will attest to me saying this all the time, but you want to colon roll. So you really want to get underneath the colon. You want to lift up. I like to use an A with my bipolar or my small grass ring retractor. So you really want to get in, lift up, and pull up so that you are able to use that, increase your surface area, pull up, and then really get under the colon and lift it up and out of the body. So again, I kind of call it colon rolling. You get underneath, lift up, and then you are trying to get away from the spleen. I know theoretically we try and wander up that splenic flexure, and we end up sometimes ending up too far over here. You really want to get back to the colon, make sure you're following the colon around that corner and not into the spleen, right? Because we want to stay out of the spleen. So those are the big things. Really making sure that you're mobilizing here, and again, coming underneath and taking that flexure. The hard splenic flexure, so using your arm 1 to pull down through their appendix. I know people want that arm to go up and over because they feel like that's how it should work, but actually the easiest thing is pulling the colon toward you and down toward the feet, then using your bipolar in arm 2 to be able to lift up and go into, and then you can actually go through your omental collar ligament that way. So that's the best way to do it. And then if you can't, drop your patient clearance joints, which do help. If you haven't done that at the beginning of the case, you can flex the XI toward the F for flexure. And then you can also switch to 30 up to provide you some more mobility. So when you switch to 30 up in those flexures, you actually have a little bit more movement of your hands. And add an assist port if you need one. If you're struggling with the small bowel or the body habitus, that's another option. And then if that doesn't work, change your medial approach. So change your approach. So then I will go to medial to lateral, or I'll pick a different place in the case to go, in the flexure to go that I think is going to work. So sometimes I'll go more proximal and start working my way that way. So just try a different place if you can't get that to work for you. So this is kind of my hard flexure tips and tricks. Again, looking at flexure, you really want your arm 1 to be ahead of you, and you're really pulling and fanning out that colon for you. And then you're going to want to continue staying ahead of yourself. And if you do have another assistant, your assistant can help you do that as well. But you want to get underneath that flexure. And then you can change, sometimes people use scissors, sometimes people use vessel sealer. Either one really works. And you just want to continue moving forward through. And then this is the hard part for a lot of our patients. They will have the sea of fat that's up in the left upper quadrant. And so getting underneath that colon rolling medially, getting under that colon and making sure and pulling that colon away from you, not toward the spleen. When you really want to pull that colon toward you and figure out how to do that with your retraction to make sure that you know where you're going to be able to work through that. So those are the most important steps as you go through there. Again, The medial to lateral has been wonderful. You go with the ligament of Treitz, you find the IMV, get underneath the IMV. And again, this is never a dissection I would do laparoscopically. Obviously, like the robot gives you so much mobility and visualization and also just fine dissection. And so you're really coming underneath the IMV. This lady had a BMI of like 19, which is the scariest kind. We're used to a little bit of fluff in Michigan. And so you can see the tail of the pancreas is coming up here. And so I'm dropping that pancreas down and we're going to go into the lesser sac. So really important to drop the pancreas down. And that's, I think, the hardest part of this dissection, because it is easy to get behind the pancreas, stay behind the pancreas, and end up in a plane that you don't want to be. But it does help because you can actually, especially if you're coming lateral to medial, you can then connect the plane that you had before, and then your flexure is completely mobilized. Because if you're stuck on these retroperitoneal attachments on here that you haven't taken out yet. So really important part of the whole. So when I do it, when we're talking, we get to the meat of this topic, right? TME dissection. How do how do I do it? So I start posterior always. It's safest. I go down to the pelvic floor as much as I can. Then I'll go lateral, and then I'll go anterior. When I say I do posterior always first, sometimes you can't. You do posterior, you get in the TME dissection, and then you go down as far as you can, and then you're stuck, especially in those fatty male pelvises. So then you have to sometimes go lateral, sometimes you have to open anteriorly, and you are literally just working your way around the colon and kind of attacking it from all angles to get it to work. And so circumferentially is how you keep moving. You take what you can and you keep going. And if it's one thing isn't working, try a different thing. You want to maximize your retraction always. So when you get in, if you are in the pelvis and your uterus is in the way, if you have a fatty preperitoneal fat pad, if you have epiploic appendages, if you have small bowel, if you have anything, you really want to maximize your retraction and make sure you can see, because at the end of the day, you're operating in a very small space. And so anything that's going to be in your way is going to be detrimental to your dissection. And then again, it's one of the biggest things I did, especially first coming out, was practicing on my non-rectal cancers. So this is the same dissection that you do in a sigmoid, right? So when you're doing a sigmoid or you're doing a left colectomy, you're going into the TME plane. You may or may not be going all the way to the pelvic floor, but it's a dissection that you can do at a time when you don't have radiated tissue, and it's, there's no stakes, right? Your stakes are when you have a rectal cancer, you need to do an excellent operation with a complete TME to make sure that you're able to give that patient, no local recurrence. And so practice on the non-rectal cancers, practice on your IBD patients or completion proctectomies. Do the dissection distally all the way to the pelvic floor, at least when you're doing a sigmoid as well, which will help significantly. So that way, when you're up for bat for the real thing, you're ready to go. So looking at the TMA dissection, I'm going to talk, this is an obese male pelvis, and this is an upper rectal cancer. So again, just talking a little bit about flexure, you really want to make sure you get underneath it. Really important as you move forward here. And he's got one of those really fatty areas. And if that doesn't work, we went medial here. So getting underneath that IMV, dissecting out the IMV. And then this allows you also to do a high ligation. So you're doing it right at the base of the pancreas so that I had done a dissection lateral to medial. And so we actually were able to connect those dissections and do a high ligation of the IMV, which then gives you the most length. So finding your plane, sacropometry is really important. Looking for ureter here, you really want to look for that sulcus. And so you can see that there, right through here, there is a change in color. And so the change in color is what you're really looking for. So sacropometry, and this is the same dissection you're going to use if you do ventral rectopexias or things like that. You're going to start the sacropometry and go down into that sulcus and around. And so the change of color shows you where you need to go. And it's very easy to get either too deep or too superficial. It's like Goldilocks, you need to be just right. And so again, I'm saying, hey, get in this TME. This is Matt Boble operating. And he's getting into the TME and opening the entire plane. And one of the things I think is really, really beneficial is making sure that back here, you open all the way so you're not working in a hole. It's really, really common that people want to just work in this hole and go into the hole. And if you can get into the TME plane, by opening the entire thing, you will be able to, especially for these obese male pelvises, open the entire peritoneum. And so that way you know where you're going and you're not working into a hole. You can see right here, we're a little bit deep. And so we end up changing that up right here so that we can get above those nerves. And that's the correct plane up here. You should not have bleeding. And it's hard to say when I say you shouldn't have bleeding, these patients have been radiated. And so they're juicy and they are, right here is the IMA and the nerves that we're talking about right down there. So he's working his way up through there. Again, just checking for ureter. So he's working his way right into the crotch of the vessel and where the vessel comes into the IMA. But again, all these patients are juicy. And so that's why robotic suction is so useful in these patients. Coming across the IMA, there's always a plane on the other side of the IMA right here that I always like to get into, and I always tell the fellows to get into, because if you can get into that plane and open that plane up, you can isolate your IMA. You'll see your ureter is going to be down here, and then you have full control of your IMA if there's any bleeding. So I love getting into that plane, coming right behind it, and then if you do have bleeding, you can just throw a stapler across it. You're safe, and there's nothing that you're going to hurt at that point. So coming across that IMA, I'm sorry, the peritoneum to the IMA. And then again, sometimes with these patients, especially because they have a lot of lymph tissue, now he's popping in on this other side to the plane that we already made because we did lateral to medial dissection first. And some of these patients, the more you try and skeletonize a vessel, the more bleeding you have. And so again, if it's a vessel like this, do not feel bad. There's your ureter, so you know everything is safe. That's the view we want. The IMA is 90 degrees here, ureter's coming across, and then you know that anything you take in this area is safe. Dropping those nerves down that we talked about before, we're staying out of them so we don't create any problems at the base of the IMA. And then this is a chunky, we do a little bit of a dissection here, and then we decide that we're going to fire a stapler across. I use a white lead stapler, obviously for any vessels, but it's very, very common, especially because this has so much lymph tissue that you try and skeletonize, but the skeletonizing actually hurts you. And so oftentimes you end up doing more harm than good. And so at that point, a stapler is not a bad idea. Again, staplers coming across, ureters here, we're safe. So then we're going to go into the posterior TME dissection. And so you can see that these are the nerves that we don't want to pull up as we're coming down. So we're going to drop those hypogastrics down. It's easy to go into this plane here and think that that's a plane, but you really want to, and this is where retraction is so important. So a lot of times I will come in from the back. I will actually open my jaws up like an A and then push forward to give that rectum retraction. And then I will have my assistant hold the rectum out of the pelvis. Sometimes they need 2 assistant arms to hold the rectums in these big, bulky rectums. And so you follow the apex, and you really want to make sure you're showing yourself the apex all the time. And so we're dropping down those hypogastric nerves. There's probably one right there. And we're staying out of so plane is right here. And again, ureter can be pulled up on the sides, and you can get it that way too. So you really want to make sure you know where your ureters are at all times. Sorry. All right, so now we're going to talk about the anterior. And so now we're unzipping lateral and then also to anterior. So again, ureter is right there, but you can see the sulcus of where this sulcus comes around, and it comes around on the other side. And that's really what you want to follow. And then you're going onto the other side. And so I love when our GI colleagues tattoo. It's amazing because it spreads everywhere. But again, staying out of ureter right here and then staying in that plane. So you really want to make sure you're not going too lateral. This is one of the pitfalls. If you go too lateral, you can end up in that nerve bundle, and you can also end up in the ureter. So it's kind of, again, the Goldilocks. How do you know? You know from experience and watching a lot. So we're going in that posterior plane, separating that TME. And what he's doing is go back, please. So what he's doing is he was actually going through, and he was pushing up. He was pushing up and out. And so that's what we want. You want to push up and out, and make sure that you're pushing the bipolar away from you. So you have the A with your small grasping retractor, you're making a kind of a 90-degree angle and you're pushing up and out of your of the pelvis itself, and then that's giving you your extra retraction. Now you have to be careful because when you're going in the TME plane, you definitely don't want to be pushing into your mesorectum, right? So the other thing you can do is kind of just gently push with your tips closed. That's another option. You just have to be careful on how much traction you're actually putting in place, because you don't want to rip your TME inadvertently while you're retracting. So that's really important. And then you just continue your TME and you continue the same thing all the way around. I have another video which I'll show you for the anterior dissection, because that one we actually went down to for an upper rectal. And this is the TME specimen. So we ended up, that was an upper rectal, and we were 7 centimeters above the anal verge. And so we actually stapled, and this was what our TME looked like. So that was for the part that we did was complete. So looking at this the next obese male pelvis, find the sulcus. So really important, again, find that sulcus right at the base of the IMA, and then he's opening along. Yeah. And again, you see this nice plane through here, and there's no bleeding when you're in the correct plane. So if you're bleeding, that's when you really have to look and see, okay, am I in the right plane? And am I too medial? Am I too lateral? Where am I? Again, we're dropping those nerves down, and I'm always moving in toward the splenic flexure. So when I retract with this arm, I'm getting in and I'm kind of hooking underneath the IMA and then retracting towards the splenic flexure to pull that out. I think a lot of people try and go into the sidewall, or they try and they'll be working in a hole down there. That's how you end up in the iliac vessels. So when you unzip the lateral side, that as soon as you see the ureter, you pop into the lateral that you already opened, which is really helpful. This one we didn't actually open up the lateral sidewall first. And so you'll see the difference between what we had done last time and this one. And so again, right here, these are the nerves that need to be brought down, which they are. We realize that, and we get back into the right plane. Continuing dissection, making sure we see the ureter, staying on top of the ureter, coming across. And then isolating the IMA and clipping it. Again, a high ligation of the IMV for length. And then this also helps when you're just working for your splenic flexure mobilization as well. So medial to lateral dissection. And then you can complete the lateral to medial dissection as well. Again, rolling that colon up out of away from the spleen. So looking at the posterior TME dissection, again, this is an obese male pelvis. This is what it really looks like. So I didn't edit. I edited, but I left in the pictures I left in, because I think sometimes you look at these videos and you're like, well, how come mine doesn't look like that? And I'm telling you, it's like we all have a chip shot once in a while, but a lot of times in colorectal surgery, like a colon is not a colon is not a colon, and a rectum is not a rectum. So this is what it really looks like. There is bleeding. You can't see. It is, you're fighting for small spaces. And so I just want you to know that you are in good company when this happens to you. So again, working that dissection plane, and I call it rocking the rectum. So really you want to start from the lateral sidewall. This is again in an obese male pelvis. You want to lift up, so you're making sure that your first arm is going in and lifting up so you can see that sulcus really well. This arm is always providing counter traction. So the name of the game in a TME dissection is counter traction and traction counter traction. So you always want to be using your first arm to be able to give yourself some traction, and then you want to use your other ones to pull away from you while you're giving yourself that tension. And if you're burning and you're not moving, your traction isn't good enough. Sometimes in small spaces you have to just take what you can get, but if you can make adjustments to help your traction, just be thinking how you can do that to help your dissection. And then again, opening that anterior, and you can see even when I pull, like my assistant, we can't move at all because the rectum is fatty. And so at that point, you can't go posterior down to the pelvic floor until you separate the lateral sidewall and the anterior sidewall, so that you can then keep pulling out of the pelvis. And so retraction is everything when you're doing this dissection. So however you can do it to get yourself in a place where you are going to help yourself. That's where you go, and you just go back and forth, rock the rectum, go behind if you need to. Again, I've got friends in small spaces, so you can see working here. There's minimal amounts that we're moving at a time. And I'm showing you this because this is real life. It doesn't always look pretty where you're just painting and everything comes up and it's an hour and 20-minute, dissection. These are difficult. And so just know that and have a plan going in. Here is a picture of the stapling after TME. This was the same patient. So this was a full TME, went down to pelvic floor and then went to staple across. Used a green load, first staple, went through force fire enabled. We had to force fire the green. Then we had to use a black. And then we had to use, I don't know how many blacks, 3 or 4. And then we ended up having to force fire a laparoscopic stapler across. Those are things that actually do happen when these rectums are so abnormal. And so, we ended up doing an anastomosis. This is what it looked like. This is Tile Pro, which has helped significantly. If you don't have Tile Pro, it's very helpful because you can actually see the robot. You can see what's going on the robot, and you can see what's happening endoscopically as well. And that's helped significantly to be able to do both. But we're just checking our anastomosis. It looks beautiful. And then obviously we did a diverting loop ileostomy after that. So really the retraction is the most important thing. And so when you're working in the pelvis, you want to make sure that you are pulling away from you and using your assistant to help you pull out of the sidewall and then pull out of the pelvis. And so again, don't feel bad if you need to add an assistant port. Robotic suction works really great for a retractor. So oftentimes I will use that instead of my bipolar to be able to make sure that I'm retracting and suctioning so that I can continue, boving with my monopolar scissors. Here's a interesting pterygoproctectomy because I think it has a lot of the same really great techniques that you want to use. And so this is looking at your TME dissection, same thing as you did before. You're looking for that sulcus, which you can see, which is right here. And I use Firefly a lot. You can see that when you go into Firefly mode, you can see that the change in color really, really well along the fascial planes. And so oftentimes I'll go into Firefly mode to obviously check the ureters, and then also just to be able to see the change in color. So we're getting into the plane here and we're using pneumodissection. So as soon as you get into that plane, it's nice because pneumodissection will help you and just easily opening that lateral, again, not working in a hole, opening the entire lateral peritoneum to make sure that we're not, and then dropping those nerves down. Opening the entire area, and I think with IMA still here, so we're, again, dropping those nerves down again. This should be a bloodless plane when you get into it. So now we're coming laterally and separating. And so you can see right here, that was just, the issue was that we were colliding. And so if that's happening, just think about how you can use your arms instead to help yourself not collide. And so really you want your retractor always to be to the left or going above you so that you're above or below. And then you want your other arm. Sometimes you have to cross where you're working like this, and that's okay. You just want to make sure that whatever you're doing is not creating internal collisions, because that will be a problem for you, long term throughout the case. So we changed our placement and had our assistant help us. And so looking back here, you see that nice TME plane, and you do see that the nerval bundles are being pulled up. And so we want to get out of that. We're dropping that down. And I love the painting. Like when we paint across, it's really nice to be able to just kind of paint when things go well and are easy. This is kind of how we do it. And just, again, using that bipolar to pull up and follow where your apex is. If you give yourself enough tension, you'll know where to go. And that beautiful plane. That isn't always so beautiful, but when it's beautiful, we'll take it, right? So again, pulling up, checking ureters. My fellows probably hear that in their sleep. I'm sorry. It's like, where's the ureter, where's the pancreas? Those are the things that I say all the time. But really important. And so it's just, again, staying in that plane and just hand over hand over hand. So if you look, my third arm is, or my grasping retractor is lifting up. So giving myself most of the retraction up, and then my bipolar is giving myself more retraction up and is really doing a lot of the work. My scissors are just painting and just really separating that tissue. Bleeding. So now we're gonna go into the lateral. So we've done as much as we can posteriorly. And again, going to 30 up helps a lot. So if you need to go to 30 up, that's something I'll do oftentimes as I'm coming where the rectum starts to come anteriorly. I'll switch into 30 up at that location. And I'm showing you this because I want you to see that huge rectocele that oftentimes happens in women. So if we're taking those the lateral stalks, and again, really putting a finger in the rectum or something finger in the vagina or something in the vagina will help you significantly to make sure you don't just plow through the rectocele, because a lot of women have rectoceles, cystoceles. And so you really want to make sure you're clear about where that anatomy is so that we're not going through anything we're not supposed to. So again, fingers in the vagina, separating out that rectocele. And so that's a pretty significant rectocele. If you don't have a finger in the vagina, you could easily plowed right through the vagina, and then also your TME is non-existent at that point. So posterior, you can screw up the TME, but actually anterior is most of the time where I run into problems, or I've seen problems happen, because you end up being either not, you don't go wide enough, or defect wise anteriorly, it seems to be a lot more problematic than posteriorly. But again, every rectum is different. No rectum is the same. And so you just kind of have to do with what works for you. But again, this is the same dissection you do in a ventral rectopexy. And so I think just knowing how you can pull up and show yourself coming off the back of the vagina is really helpful. And in a male, you want to get those seminal vesicles. And coming off the back of the seminal vesicles keeps you out of trouble, so you're not in the neurovascular bundle, but also is a way that you can just make sure that you're still getting your full TME anteriorly. And so here, this rectocele finally is breathing and is separated from the rectovaginal septum. It hasn't seen the light of day in forever. I'm super excited about that. And we are not going to staple. We're doing intrasphincteric proctectomy here, so it doesn't make a difference, but you never want to staple the vagina. That's another thing that can happen if you don't make sure you separate that rectocele, is you can come across and you staple the vagina and everybody's sad. So we'll just avoid that. Going back to that posterior dissection, now I'm, just working our way around circumferentially, because you can't go in any, it's not, when we say do posterior, then lateral, then anterior, it really means you're kind of going to go on that way, but you really have to just go for what you get. And here's the pelvic floor. So we're down to pelvic floor. We're coming down to the bare area. And then for an intrasphincteric proctectomy, you can take the levators off of the insertion, and then also go from below, do your, put the Lone Star in, do your intrasphincteric proctectomy that way. And then make sure that you have, you've completed everything. So again, one thing I will show you is on the back. So we'll get to that in just a second. But basically what I like to do is I'll have whoever's my operator. So a lot of times we'll do these cases together. I'll help them go from below and actually find the sacral promontory, the coccyx. And then I will have them place a needle on top of the coccyx in the path that I would follow if I were going from below. And then that way I know what path I'm supposed to follow when I'm going robotically, so I don't wander off course. And then I'll actually make a U shape to go through the posterior levators. I use the same technique because I'm doing APR. And this was for significant perineal disease, so it gets a little bit scarred here. But basically, I'll go down as far as I can, and then I'll go up as far as I can and make a U shape. So that way, when I go from below, all I really need to do is pop in the skin with a few centimeters and then connect that lateral. And then all I have left to do, I deliver the specimen and do the anterior dissection last. So that's what's helped me. I have I do a end to side, a Baker anastomosis. From an efficiency standpoint, I like to take my vessel and then I will actually turn 90 degrees and go right up to my colon. I'll do that one no matter how I'm doing my anastomosis. And it's just helpful because I'm already there, everything's ready. And then I'm leaving my colon there to kind of make sure that when I use ICG later, it's going to work. So that's how I like to do my Baker anastomosis. So we didn't talk a lot about anastomosis because I focus most on the actual TME itself, but that's one of the ways that you can do it. I like to, please put a sizer in the rectum and also put a stapler in the rectum. This is why. There's always a cuff, not always, sometimes there's a cuff at the rectosigmoid when you think everything's going to go in well and everything's going to be fine. And if you don't check that area, it's easy to go across the rectum in an area that you think is going to work. And then you do all the work, you staple across, and then you go to put the stapler and you can't get it all the way to the end. And that is a huge bummer. So one of the things I've learned, I think it happened to me once or twice probably, and then I was like, hey, we got to do this. So that do yourself a favor, just put the sizer in the rectum. You will know where you're going and you will not be sad when you don't have to restaple. This is one of my earlier endosides, and I'm leaving this on here because this is a speed of 20, right? 20. So, and it still looks like it's taking forever. So these are one of the most frustrating parts of the, you guys have probably done a lot of these and, your fellowship by now, hopefully, but I'm leaving this in here because I just want you to know that there's a learning curve. And so you just have to give yourself some grace when you are going through a learning curve or transitioning to something you haven't been doing before. You definitely want to, know it's not going to look pretty all the time. It will get better. You'll gain your efficiencies back. But it happens to all of us, and it's okay. Changing things is hard for when we've been doing things one way, but if it's beneficial for the patient or it's doing something that's, an intracorporeal anastomosis or whatever it is, we always like to know what we're doing, and sometimes we just don't. So those moments, we just have to give ourselves grace and make sure that we laugh at it later. There's sometimes I was looking at my videos and I have a 2015 rectopexy, which was one of my 16, I think, rectopexies. Was when we first started doing rectopexies. And I looked at it, I was like, who is operating? And then I was like, it's me operating. But it's important. Keep your videos because you will definitely, look back and you'll be like, oh, look at how far I've come. Look at what I've learned. Look at what what I used to do, what I do now. And so I think it's really important for video review, mentoring, and also just to see your progress as you go along. So that's one of the things I think is really helpful is video review. Coming across here, making sure I use ICG, stapling. You really want to make sure you have 2 centimeters between the anvil itself and the staple line. It's one of the things I think that, when we look at leak rates, you really, really want to make sure that you don't have an area here that is right on top of the anvil, because then you're going to have an area that's devascularized, and that is not going to work. I use endoloops to close my common enterotomy, and then an ICA happens. Just for the interest of time, I know it's 7:55. I think I'll stop here. And then I have some more, videos. I'm happy to answer questions. I think the take home points are, it's going to be hard at first. You're not going to completely know the planes. If you need help, ask for it. I would definitely tell you I'm lucky enough and fortunate enough to be at a program with supportive partners. And so I think being able to ask your partners for help, especially for your first few TMEs, don't feel bad about it. Make sure you're practicing on the ones that don't matter. So when it does matter, it's a lot, the stakes are a lot lower. Be ready to be flexible. It's very important. You get the suction out, and people make it look easy. It's not always easy. So just give yourself some grace, and experience will come. It will work out.
Thank you very much for that. That was incredible. I'll put a couple of quick plugs in. The man himself, Dr. Solomon, will be giving us our lecture next month on the intracorporeal anastomosis. So he'll have plenty of videos. Maybe he'll even pull one out from when you were a fellow. And then in June, he's going to come back and talk about how to kind of manage and edit your videos and video review, because Dr. McClure mentioned that being super important. And so we'll kind of go through how best to do that and how best to keep your videos. We have a couple questions that I'll moderate, but I wanted to start with one that I had so that other people have time to enter them in. So when you were first kind of learning how to do the TME early in your practice, I'm not sure if you had, I guess you had Dr. Cleary in terms of senior mentorship, but what was your backup plan as you were learning that? Some fellows are probably going to go places and they might not have strong senior support as they're perfecting some of their robotic skills. So like if they aren't making progress on their teaming with the robot, like what could they consider doing, since you said open would not necessarily be easier?
Yeah. So, I mean, when I first started off, there wasn't a ton of support from a standpoint of being, because well, you just have to make sure you have a plan in place. And so I guess the first thing I would say is I didn't have Dr. Cleary always. And when I didn't have Dr. Cleary, I did have to open. And the reason I know it's not easier to open is because I had to open. And then after I had to open, I was like, why? My shoulders hurt, everything hurt, it was miserable. And I was like, why? I can't see where I'm going. I'm using a ligature through what? The TMEs were still complete, but it definitely wasn't perfect. So I think the first thing is, if you have to convert, it's not a failure. I want you to know that. Like, it is absolutely okay. The patient safety is most important, and you will get it done however you get it done. So whatever you are comfortable with is what you can always fall back into. I think if you have TMEs and there are, things that, like, I did, my first case was an APR. Like, I would not recommend that, right? And so, but if you have to, and those are the cases that you're getting, if you can plan to have someone there that's helpful, that does TMEs, that's possible. The other thing is, I think Intuitive has an opportunity for proctorship. So I think as you come out, if you need someone who knows what they're doing and you need someone there that can help you, those are really great options to bring someone out and actually like help you through that. And so they will help you with that if you need help with cases. And then again, just go to what you're comfortable with. At the end of the day, I know it's not easier open because I did it, but you have to like give yourself a lot of pep talks throughout the case. And, at some point you have to figure out, how long is the case going to be? Is it over 6 or 7 hours? Am I putting the patient at risk? Do I need to readdress? So I think you take all those factors in when you're making a decision as far as what's going to work for you. I will tell you, from a vision standpoint, it definitely is easier robotically, but it's not easy anyway. So you just have to, decide what's going to work for you for there.
Yeah, that makes sense. A question from Surgeon from Dr. Johns. Any pushback about the ICG not being FDA approved for the ureters? He wasn't sure if this is something he's just heard or if it was true or not.
Not at all. We have never had pushback. Our urologists love it. They use it. Not at all.
Okay. Next question is from Dr. Schenker on Surgeon. She asks, how do you manage a large rectocele when you're doing a TME dissection?
Oh, I cried. No, I'm kidding. Usually I'm like, Shanker, get your finger in the rectum. So get it out of the way. Stay out of it. That's what matters. So I think that's the most important part, is making sure you have enough retraction to get it out of the way, and then make sure it's, you're able to not staple across it. I think is the biggest thing. We're not fixing it at that point. Knowing that it's there. And hopefully I've known that from the preoperative discussion with the patient, and also the fact that I can see it and I'm staying out of it. So I don't, I think the only way you manage is staying out of it and knowing that it's there.
Okay. Next is a question from Dr. Robertson from Surgeon. Do any of you feel there is any difference between end to end or end to side? I presume this is for like intracorporeal anastomosis.
So the data on intracorporeal anastomosis would show that there is a decreased leak rate for intracorporeal anastomosis versus extracorporeal anastomosis. So I think the first thing is, I would always prefer an intracorporeal anastomosis if I can. Now, that being said, sometimes that doesn't happen. Sometimes people aren't comfortable, whatever works. When we're talking about ICAs in general, I think the benefit of a Baker is that you're coming out the antimesenteric side. So especially if we're doing it for diverticulitis, you aren't worried about diverticula. I think one of the most frustrating parts of surgery for diverticulitis is when you have to kind of keep working your way up the colon, because you're ending up finding another diverticula. You're having to include those into your staple line. So I think when you do a Baker, I don't worry about that nearly as much. And also for me, technically, it's easier. So because when you do an end to end, robotically, you still have to come across it, and then you have to clean it off the same way you would normally if you were open. And then also you have to make sure you include any diverticula. Now, the downside to a Baker is you lose some length. So you probably lose about 4 centimeters at the end of the day, 4 to 6 by the time that you make your anastomosis, make your colotomy, put your your anvil in and all that other jazz. So if you're worried about length, you might an end to end might be a better option for you. Now you can always do a hand sewn. That's always an option as well, right? So and that's the nice part. Robotically, you can do all of those things and whatever you need for the patient. So that's kind of why I prefer the Baker. But an end to end, if I'm worried about length, I'll do as well.
Got it. Let's see. Next is a question from Surgeon from Dr. Nemhard. She says, any tips on setting up a coloanal anastomosis robotically for a really low rectal cancer?
Setting up a coloanal anastomosis. So like when you know you're going to have to do a coloanal, trying to get into the intersphincteric plane, I'm guessing that's what she's talking about. So, and if not, just keep typing and I'll keep answering. But really going as low as you can, taking the, when you get down to the pelvic floor, you want to take the levators off of basically the origin and then continue into the dissection plane if you can. I oftentimes at that point can't really see where I am. And so oftentimes down below, I will have the patient set up and then put them in like lithotomy position and then get the Lone Star in from below. And then you can actually work up above and from below to get into the appropriate intersphincteric plane if you need to do that when you're working with the coloanal anastomosis. And then the other thing if you're going to do a coloanal hand sewn, I think making sure that you're able to hand the colon through is going to be important because they're going to pop through and you're going to lose insufflation. And so making sure that you have some kind of way to hand your partners down below the colon so you don't lose anything. And then really just getting your first few sutures in. So I always will, when we're doing the coloanal, making sure that you're ready to have you have the sutures already placed. And then when you grab the colon and it comes through, you can lock it in place so you don't have any twisting or anything like that. Because you really want to make sure with orientation, you don't have any twisting as you're coming down. Again, with coloanal, you're going low. So you need to make sure you've mobilized everything completely. So I would recommend making sure that you have all your splenic flexure completely mobilized. Your length is impeccable because you're going to need all of it.
All right. Next question is from Dr. Chen from Surgeon. What arm do you like to place with robot suction? Since you're giving kind of the retraction with arms 1, 2 versus the dissection arm of 4.
I like to use it instead of my bipolar. So really I use it instead of my bipolar when I'm doing robosuction. So I can push up with my bipolar and then I'll continue to bovie with my monopolar scissors. The nice part is you can literally go in any arm. So if you need it, if you're coming from an angle that you really need it in another arm, sometimes if I'm working on the other side, I'll use the robosuction to hook around and pull over. And then you can bovie with your, with my scissors and arm too, or where my bipolar usually is. So I think like whatever you need at that time is where you put the suction. And that's the best part about the XI is you don't have to pick, right? You get to have all the things.
Yeah. Another question from Dr. Robertson. Do you always reinforce the area around the anvil?
I usually don't. You mean for my intracorporeal? Yes, I do. Yeah. And I will tell you, because one day, Bobo and I did an experiment and we were like, okay, this is what we're going to do. We're going to do it. And it looked totally fine. We brought it out and we both were like, okay, this looks fine. We're going to do it. It looks like we don't have to reinforce the anvil. And then we did it. And then we had barely a donut. And after that, both of us were like, all right, we're going to put a suture on the anvil. Unless there's, I know some people will use a spike or they'll make a small seromuscular burn and they'll pop that anvil through. And that might be a way that they don't necessarily always have to reinforce it. After our experiment, I have not been able to go back. So I will always be reinforcing the anvil.
I 100% agree with that. A question from your former fellow, Dr. Diaz. Are you always placing ureteral catheters and ICG for LARs and APRs, or is it selective?
I always do it for any pelvic surgery. So LAR, APR, and then I do for any redo ventral rectopexies, I will always place catheters. And sometimes even for Crohn's. So if I have a right-sided Crohn's patient who I'm concerned about that the ureter is going to be involved, they have a big ileocolic phlegmon, I will also place a ICG plus or minus a catheter on the right. It's nice because if you put the ICG in and inject, you don't have the stent in the whole time. If it kind of depends if I think I'm going to ever need to convert or if I'm going to be able to do it robotically. But for the most part, I can just inject. And then again, I have cysto privileges, so I have to put a stent back in, I can. But normally I'll just inject, I'll leave the ICG in, and it's I never said it's there. I never said it's there.
Agreed. Question from Dr. Walker on Surgeon. What do you do when or if you get into the rectocele?
You just repair it. So I think the nice part is the vagina is very forgiving, and so you can just repair it. I will just throw some. I just use Vicryl, but the one thing I probably will do is put some kind of fat in between that anastomosis, because you want to make sure you have a low anastomosis, you have your rectocele there, you just don't want to have a fistula. And because we already have a higher leak rate when you're already there, making some kind of like augmented pedicle flap or something that I can put down in between the rectum and the vagina is really important to make sure that you're not going to have a fistula formation.
And then another question from Dr. Chen. When placing the anvil for a baker and the conduit, what instrument do you recommend in arm 4? Vessel sealer versus another bipolar versus the clip
So I
applier?
actually use, I love the clip applier. I'm trying to convert Bobo. I'm trying to convert it. Listen, this is what I learned, y'all. This is what I learned, y'all. You just can't clutch the camera. If you don't clutch the camera, you will not have roll grip. But if you clutch the camera, so I love the clip applier. The Cobra is really wonderful as well. That's another option. You can use the tip up. I prefer the clip applier in arm 4. And I will actually, what I like to do is make my colotomy, which I started doing transverse, like across the bowel. And then popping in, making that proximal colotomy, popping that anvil in, and then pushing down with either my tip up or my bipolar, which is in arm 1 or 2. So I really like the clip applier, but again, some people like the Cobra, there's a cardiac grasper, which people love, the ProGrasp, whatever you want. I still have 4 months to convert Bobo. So we'll see what happens.
One more question from Dr. Shanker. You won't convert me, but I will let you continue trying. She says you've done an amazing job when you came creating support teams and turnover time efficiency. So do you have any advice for new surgeons, either young attendings or fellows that are about to graduate?
Yes. So know what you need going in. I think it's so important. So number one, when you apply for a job, when you interview for your job, just make robotic block time part of your life. Make sure you get it, and make sure you don't get it on Friday afternoons if possible, right? So that's the first thing, is ask up front. Make sure you ask for the things that you need. So come with your preference cards, get your preference cards from people that however, this person likes to do a right, this person likes to do a left, whatever you want to do, come prepared, because that'll be a lot easier. When you get there, meet with your OR staff and tell them what your expectations are, because I think it's important for them to know how you're going to roll, and make sure you get to know them. You need to get buy-in from them, right? So they will do anything for you if they like you and if they understand your vision and your why. So I think getting some face time, especially in the beginning when you're there, you're not super busy, is really important, because then they'll want to turn over for you. They'll want to do all those things for you. So I think, and also when you first get there, learning the culture of the institution. So every institution is going to be different. Some institutions are already going to be up and running like that, and you're going to be able to come in easily. Some institutions is going to take work. You cannot come in and plow through that. You have to just learn kind of what the culture of the institution is, and then figure out how to get yourself in the key places to make it happen. It will happen, but it's going to be a marathon and not a sprint. So I think recognizing where you are when you get there is important, as far as, because the last thing you want to do is show up and expect all these things, because you can expect them. We love that, but they're just not going to give it to you if the culture isn't set up for that. So you might need to do a little bit of work. And again, please, that's when you can reach out to us. We've done this, this isn't the first time we've done it. Don't reinvent the wheel. We can help you get through that, through those learning curves. But I think really just establishing yourself as part of the team, coming prepared with how you want to do everything, and then making sure that you have face time with your team is going to be really, really important. And then also meeting leadership. So figuring out, do you have a robotic steering committee? How does that work? And then getting involved in those committees will help you learn how to help make the changes that you need to make potentially.
Awesome. That's perfect and super helpful. Thank you so much for tonight. All of that was amazing. I loved all the videos and all the tips and tricks, and I think everyone else did too. We had wonderful engagement with all the questions. So please feel free to send us more questions. We can pass along to Dr. McClure, and we'll get this video posted in the next few days.
Awesome. Thanks, y'all. Have a good day.
Good night, everyone.